All right, let's talk about orthotics. Let's go through this. We're good timing. I want to get through the information, so let's get to work. So, orthotics. We all understand the value of orthotics in the treatment of our patients and want to ensure our documentation supports the medical necessity for that. In an effort to ensure providers have a clear understanding when it's appropriate to bill for custom orthotics to any H&S contracted payer, not just Blue Cross Blue Shield, but H&S has modified the policy. This is such a riveting topic, it even came up at dinner last night. We started talking about orthotics. So the chief complaint, objective clinical findings and diagnosis documented in the healthcare record must clearly support the need for orthotics. So docs, your wheels started turning. What are those chief complaints and objective clinical findings? There must be appropriate treatment plan which includes orthotics and which clearly links the need for orthotics with the goals of the treatment plan. And there must be clear clinical documentation indicating which explains why non-custom orthotics would not be appropriate for the clinical or condition or diagnosis. And the clinical report provides evidence that foot orthotics have been customized from a mold or scan of the patient's foot. So how many of you are doing custom orthotics in your office? A good number of folks. So this is real important. Obviously, it's not just one doc, it's actually all of us documenting and providing these services on a consistent basis, and so this is important. So the custom foot orthotics are medically necessary to support or aid in the treatment of an illness or injury as described below. This is a highlighting page for you. When there is a primary diagnosis of foot pain or primary diagnosis of a foot condition, plantar fasciitis, pes planus, pes cavus, provided that documented objective clinical findings clearly link the prescription of custom foot orthotics to the primary diagnosis and or chief complaint, as well as the prescription of custom foot orthotics is consistent with the goals of the treatment plan. You got to weave it all together. Whoops. The custom foot orthotics are medically necessary to support or aid in the treatment, again, as described below. In the absence of a primary diagnosis of foot pain or a foot condition, custom foot orthotics may be medically necessary when provided concurrent with chiropractic manipulative therapy. So let's go back to this again. A, when primary diagnosis of foot pain or primary diagnosis of foot condition, and again, points 1 and 2, documented objective clinical findings clearly link the prescription of the orthotic to the primary diagnosis or chief complaint and is consistent with the goals of the treatment plan. And then over here, in the absence of a primary diagnosis of foot pain, then you've got to have documented objective clinical findings clearly linking the prescription of custom orthotics to the primary diagnosis and or chief complaint, and the prescription of custom orthotics is consistent with the treatment goal. So it's all going to kind of work together on that regard, okay? So H&S has provided a new waiver. Yes, Doc. Mm-hmm.
While that's certainly a customization to the height of that, how does that really work with something guidelines? Because it's going to be very clearly related to
Okay. Go ahead, Dr. Bender.
I think it just adds to the degree of medical necessity that you're going to be providing when you add more clinical evidence that custom orthotic is needed. If you're going to be adding that height to a custom orthotic in one shoe and not in another, whereas a store-bought unit is going to be equal on both sides. Is that the...
Maybe I should be more specific. I'm just saying, instead of doing a custom molded orthotic, doing just a shoe lift to balance them out so that they're...
Like a heel lift.
So that...
Oh, shoe. Right.
Or even doing custom
shoes, right. Yeah, I'm not sure they're covered services. Right.
Okay.
But one point I would maybe emphasize between the two policies, one with a foot condition, one without, is the one without is the more precarious one for the doctors in this room. That's where you really need to draw in the kinetic chain arrangement between a low back or a knee problem to the foot problem.
Right.
So that, if there is no foot condition causing the foot pain, what is the foot problem doing to the rest of their body? And that's the need you have to clearly state.
Gotcha.
That was the challenge with the two doctors that we were talking about. Primarily, it was, again, a short leg issue, and Dick, they had cervical pain or something, thoracic pain, and
Hip pain. One, I
hip
think,
pain,
was hip
right.
pain.
So again, if there's a clear, pes planus, I think that everybody should get. It's when it isn't that we just got to make sure the documentation clearly links it to the goals of the treatment plan.
Right. So before I ask that question, just to go back to this doctor's point, if you were doing custom orthotics, but part of that custom orthotics, that scan, is you were adding heel height to that, then that would be a covered service, given that you do the documentation of that. But if you're doing just one without, yeah.
So in the case of, foot lovers will have a scan.
Right.
Or three people, do you think it would be wise to take pictures as well? Take pictures of the...
Well, I don't think it'd be necessary. The scan is sufficient, and these doctors provided the foot leveler scan, which really gives it's part of your documentation. But if you wanted to take pictures so you see that bowing of the Achilles or whatever, I don't think there would be a downside to do that, especially in this day and age when you can do it all digitally, and then you can just add it to your file. So good. Any other questions on orthotics? I use a lot of non-custom orthotics in my practice, so you've got a little bit more latitude to work with that. But obviously you need to distinguish with your patients that would be a non-covered service. So if you're billing an orthotic for a non-customized orthotic or a semi-customizable, that's not a covered service with any of the H&S payers, so you'd need to have them sign off on a waiver for that. And speaking of waivers, H&S has created a new non-covered services waiver specific to custom orthotics, and you have that. And if there's any doubt that the prescription of orthotics is not completely consistent with these policies, just have the patient sign. So, how I would do that in my office, if you're sending out some custom orthotics, you say, I believe there's a medical necessity to have these done. I'm not quite sure it's consistent with your insurance company's policies. So I just want you to sign off letting you know that we will bill these to our best ability to be able to get those paid by the insurance company, but if they're not paid, then you would be responsible for that. Okay? Well, let's keep going. A note about family members. This just kind of thrown in there. Worth mentioning is that we cannot bill insurance companies for care provided to our family members. Family members include spouse, parents, children, siblings, those kind of things. I know that's been a bit of a problem. You got that big $5,000 deductible, so you have your family coming in to get adjusted and to eat up that deductible. That is unethical, and you are to not do that. Okay? All right. How many of you are billing are seeing chiropractors or chiropractic family? How many of you are billing that? Not many, huh? Nobody's billing it. How many of you are seeing them is what I meant to say. Okay, most of us. Okay, if you live anywhere near a university, I'm going to probably see some of your kids, and that's always a great experience, but that's a little different. So we're going to talk about strengthening the foundation and building your note. So what we're going to do here, there we go. This is Dr. Binder's note. Now, this was from May 16th. I'm going to tell you when I asked him for this note was like on May 17th or May 18th. So he didn't pull up the note and make it extra special, put extra special sauce into it or anything like this. This is his note. So what you're going to get to see is an initial note, a progress note, and then a final re-exam note that we're going to walk through. So this is what you would see in his office with a few highlights there. So I wish there's a little bit better way to do this, but this is the best way to do it. So it says, Mr. Smith entered the office today for complaints arising from a motor vehicle accident, 2 automobile incident, and has completed the patient intake questionnaire. The questionnaire was reviewed and annotated by the exam provider, yada, yada, yada. Goes through that. Mechanism of injury, he goes through that. Was positioned in the front seat passenger of the vehicle. When questioned about wearing seatbelts, he replied he was restrained. Okay, my patients don't use the word restrained. When I ask them if they have seatbelt on, they say yep. Okay, but restrained is a better word. He goes through and talks about the mechanism of injury, talks about the vehicle, police did arrive, so all that stuff's pretty straightforward. You should be having most of that information in there. Then it goes into history, chief complaint. So let's look at that. Reports an acute complaints of posterior head, posterior cervical or neck, thoracic, lumbar, chest, sternal, and abdominal pain due to the impact of the auto accident on 5/11/18. Frequency and quality of care he gives. Radiation of symptoms, the VAS, modifying factors, relieved by prescription medication and aggravated by any movement, and goes through all those things. Bending, carrying or lifting, changing positions, coughing or sneezing, getting out of bed, car or chair, looking over shoulder. Again, pretty self-explanatory. Previous episodes, no history of any. Now here's a perfect example. Let's say this person had 3 motor vehicle accidents in the last 5 years. That's very important to your care plan with this patient and how you'll treat those. So this would be a great time to put that in there so it provides more levity to what's going on with that patient. Previous care, received medical care is described above for this condition. Confirms recent diagnostic testing, goes through ADL, functional deficits, explains sleeping has become difficult when lying down, rising out of bed, getting to sleep, staying asleep, and changing bed, in bed, rolling when he does this for more than, at all times, 0 seconds. Patient subjective goals and goes into that. Explains personal goal for starting treatment is to have no functional limitations. That's a very complicated response, right? The patient just wants to feel good and be able to get back. So that is good. So it goes through the systems review, past, family, and social history, all this stuff. Very comprehensive. Now let me stop and ask Dr. Bender, where do you get that social history? Are you asking the patient those questions, or are they giving you that information, like filling out your form?
They give it to us on the intake side.
All right, so they're doing their intake, getting this information. Are you putting it into your system, or is your staff putting it into the system?
Our system downloads it into the note
Great.
from the intake process.
All right, so they're doing it. They're getting on some kind of a instrument, iPad or something, putting that information in. Good. So all that stuff is coming from the patient, and very nice. All right. Objective goes through vital signs, presentation. Okay, vital signs, range of motion. And then it goes through the orthopedic tests that were performed on the patient in order to localize cervical pain, downward pressure. I don't need to explain that. So cervical compression, spinal palpation, and then goes into the palpation findings. Static and motion palpation reveals spasm, hypomobility, and endpoint tenderness. And he goes to specific segments. Very nice. Palpation of muscles, relieved hypertonicity in the following areas: cervical, mid, thoracic, lower thoracic, and lumbar. And then x-ray studies. So we were talking a little bit about the x-ray report and x-ray studies of this. He's just put a really specific, to the point, little assessment of the x-rays. I've told you in the past, I use a DAC bar to review my films, so I add his information into my note, so that is in there. So it's a little different, but sufficient in either way. X-ray studies of cervical spine, he goes through the views. These are read by Dr. Steve Bender, goes through and gives the spina bifida C2, and he's got biomechanical things, that are there, and certainly any degenerative things, and goes through. I also have reviewed a CD copy of the CT scans of his head, neck, chest, abdomen, as well as the ER physician notes of 5/11/18. Functional assessment. So is completed by the patient. Low back disability questionnaire, rating a score percentage of 48, which demonstrated functional deficits or disability. And another function of the neck disability pain index, and oswestry and headache disability index. So he's got 4 outcome assessments for that one patient, covering all those primary chief complaints with the patient. So now we've gotten through subjective, objective, now we're into the assessment portion. Patient is good health and expected to make good process and recovery with some residuals based on the history of severe osteoarthritis and severity of the initial episode of injury, and nothing noted as contraindications to chiropractic here. It is reasonable to believe that his recovery may take longer than an average patient with an uncomplicated case. We talked a little bit about that earlier today. So he is already creating some, that's in the prognosis, kind of letting us know it's a little bit more complex patient. It's going to take a little while to get this done. This is why when there are 4 people in the car and they're in a motor vehicle accident, they all shouldn't have 20 visits, or they shouldn't all have 15 visits. Everybody's going to respond different based on their predisposition, position in the car, all that stuff. So again, being creative with that. He's currently in the acute phase of care, prognosis. At this point, he's undetermined at this time. He's got short-term goals in here for the patient with specific percentages, and within 3 to 4 weeks of treatment plan. The nature, so now we're into our plan section. The nature of the proposed treatment plan, along with the probability and significance of any risk and other treatment options, were reviewed with Mr. Smith prior to the beginning of care. It was clear that he did understand all of his options, decided that he would be starting care. This is all informed consent. And then we were talking about therapies. Electrostimulation in the form of pre-modulated current will be applied to the cervical and cervical dorsal areas. The cycle time will be set at continuous. The beat frequency goes through that. Electric stimulation performed for 8 minutes on the affected region to reduce spasm, improve range of motion, and alleviate pain. The assessment and treatment plan will remain unchanged until the 12th visit or within 30 days of the previous evaluation, or whichever comes first. Where did that come from? Okay, that comes from the practice guidelines, and so he's able to copy and paste that. Changes in condition for better or for worse, or any new injury would be noted. And then goes adjustments to delivered. He gives specific spinal segments and goes through that. Diagnoses, bingo. Okay? There we go. I just hit that was the old version. I had it sitting right here. I was looking for some notes in this, and Dr. Bender had given me an updated one, and I clicked up the wrong one. But it's the same note. All right. Let me kind of catch up here. So I wanted to hit some of these highlights that Dr. Bender wanted me to do. I also, as I mentioned, reviewed the CD copy of the scans, getting that information in there. Again, we talked about that earlier. Just anything, any interactions, any conversations, any documentation, that needs to be noted in your note. And then as we come through here, as I mentioned, based on that history of the severe arthritis, he's essentially setting the stage for the patient, letting us know this is going to be a complex situation. All right? And I think we hit all those plans. Treatment plan of 3 times a week for 4 weeks. He did that. The patient returned in 2 days for follow-up care. Okay, now we're on track. So now we're at 6/11. This is his progress exam. We're back into this. Same thing, goes through, sought treatment today, complaining of occasional dull, aching and tightness, discomfort of the mid-back. He rated the intensity of discomfort on the VAS as a level 3 on a 1 to 10 scale, with 10 being the most severe. Boom, 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 goes through that with the low back pain as well. So now we're down into the objective. We've got the objective findings, the diagnoses in there. The following symptoms stayed the same, none. The following symptoms had gotten worse, none. Overall, his condition has gotten significantly better. Okay? Range of motion, I don't need to go into that in detail. I want to hit some of these. This is one of the things I really like about Dr. Binder's notes is, for instance, flexion, normal's 45, was 40, now is 50, was 18, now is 35. I don't have that ability to do that in my notes, but I really like that. So you can see that change, that delta with each exam. I think that really makes things easier to read. And look at these down in the, was 22, now 50, 26, 45. You know, again, the above findings coupled with the updated outcome assessment scores indicated a significant positive improvement in his condition since the initial exam was on 5/18, so, or 5/16 rather. So we're about a month out from the initial exam, and you can see the progress with the patient. And I'm going to go through a few of these other things. We're going to go right down to assessment. And here it is, feels the treatment has improved his ability to get in and out of the car. That was one of the things that he mentioned. And lay down, sleep, fall or stay asleep. Remember, when he's rolling over, he was getting sharp pains, and rise out of the chair, and has now changed about 35% since the onset. Okay? And he goes through and explains all those things. He's been reevaluated analyzing the headache disability index questionnaire. Beginning score of 34%, and the goal score was 10% or better. The current overall percentage is 0, with an overall change of 34%. Okay? So going through, and he's hitting all those areas. So he did that baseline. Now he's showing the progress. And then down at the bottom, I like this too a lot. In consideration of the findings from 611 re-examination of the complaints, of Mr. Smith's complaints, the outcome scores and my examination findings for this condition, continued treatment is necessary to accurately determine when he reaches MMI. The new treatment plan will be modified to decrease visit frequency. Okay? Goes down, give the prognosis, short-term goals. We seem to be exceeding these goals. Our new goals will be to decrease visit frequency without losing our progress made, and look for him to reach MMI within 4 weeks. So if he's there in 3 weeks or he's there in 5 weeks, you know, it's fine. The treatment plan is being revised to 2 visits every week for 2 weeks. Change the condition for better or for worse, or for any new injury will be noted. Beautiful. Diagnoses. Down here. And then we get to our final exam. All right? Any questions? We've gone through the initial exam. We're not going to go through all of his daily SOAP notes. We've done the progress exam. We've showed progress. There's still work to do. And now we come into this. And the date of this one is 7/16. All right, sought treatment today, complaining of occasional aching discomfort in the mid-back. He rated the intensity of discomfort using the VAS on a level 2 on a scale of 1 to 10, with 10 being the most severe. The discomfort was reported to increase with prolonged sitting. The discomfort was reported to decrease with rest and chiropractic care. Goes through all of the objective findings, the diagnoses, vitals. All right. This is another thing. I didn't notice this earlier, but the patient's 286 pounds. That's a big patient. That's going to affect the progress as well. And again, now we're looking at ranges of motion. And look at that. He continues to see that progress, doing a great job with the patient. Was 22, then 50, now 54. Just great. Not full ranges of motion, but you see steady improvement. The above findings, coupled with the updated outcome assessment scores, indicated not much change in his conditions. Objective findings since previous reevaluation on 6/11, which indicates he has reached MMI. He's improved functionally, objectively, but those outcome assessment tests are not showing a lot of change. Again, why is he not? This may be the best he ever is. And what we don't have is understand the pre-injury status of this patient. This patient is probably better now than he was before the accident. But again, you see how this information sets the stage to make clinical decisions for you rather than doing it based on pain only. Re-exam goes through that, spinal palpation, palpatory findings, the x-rays were the same. Those are the original x-rays. Goes through, so some of that stuff carries over for this exam. An initial detailed examination was performed on 5/16, followed by another one on 6/11, and now we're at 7/16. So that's where we're at. So he goes through the assessment, outlines everything, and then down here in the bottom, in consideration of the findings from 7/16/18 reevaluation of his complaints, the outcome scores, and my examination findings for this condition, it is my opinion his injuries sustained in the 5/11/18 auto accident have reached MMI. Therefore, he's being released from active care following today's visit. He is being placed in a supportive phase of care now. And then short-term goals. Our goals were to decrease visit frequency without losing our progress made and look for him to reach MMI, which we saw, right? The ranges of motion continued to improve. Within the past 4 weeks, which he has accomplished, go down to the plan, what he did for that day. And the patient is being released from active care following today's visit and will be placed onto a preventative monthly supportive plan going forward. He adjusts the patient that day, diagnoses, and that's it. Okay? Yes?
How important is it to document that you put the patient on a supportive care?
It's mandatory because you want to you want to show that flow of care where the patient is at.
Dr. Sharp, maybe repeat this question.
Oh, the question was, how important is it to show that you've moved the patient onto a supportive care plan? Is that correct? So I would say it's mandatory because you're releasing the patient and that you are establishing when the patient comes in on the next visit that will be under a supportive or maintenance care plan. Okay? Any other questions on his notes? All right. Did you have something else you wanted to add to that, Dr. Bender?
I'm not sure with Dr. Pierre's question that it needs to be mandatory that you move everybody into supportive care. That might be what
Yeah.
you were thinking.
Right. Just
And,
if you were
know,
saying.
in this case, this person was being moved in. We just wanted to make it clear that he was no longer active care. But he could have been, I could have said, he'll see me whenever the hell he wants to see me, you know, whatever.
As long as there's something that's clearly
Right.
that you're dismissing the patient from.
Active care.
Right.
I think that's
Gotcha. That's good clarification. Good clarification. Okay. Anything else? Pretty good notes. Okay. Anything earth-shattering there? No, it's pretty simple, to the point. I like his layout. This is the question. That's your standard right there. That's what you're working towards, right? So, Dr. Bender, how long did it take you to build your initial note for that patient?
Obviously, it depends on the complexity of each case, but in this case, I would say probably 10 minutes.
In your progress exams?
Progress exams are probably 5 minutes.
Okay.
Yeah.
So you think about that. Thank you. And think about your time and energy. You want to have these good quality notes and how much time. I hate to hear docs saying, I spent my Saturday morning or Sunday night at the office, or I'm doing notes till 11 o'clock at night. If it's taking you more than, of course, it depends on how well you set up your EHR, if you've got an EHR system. Therein lies the rub right there. So if you spent the time to organize it, and I will tell you that Dr. Bender has spent a great deal of time formatting this so he can produce that quality note in 10 minutes. So that goes without saying, but make sure you're spending the time. So if you have 2 or 3 new patients a day, or you have 6 a week, that's only an hour's documentation time to do that. And so when you start really breaking it down, it's not as difficult as you might think. The other thing that I would say, and I'll be honest with you, there are 2 things that I would say about myself. I am not very disciplined. I'm easily distracted. Well, there are many things I'd say, and I'm a little lazy. So because of those character qualities that I have, right? When I'm in the office, I have to be just the opposite. Actually, I'm not very lazy, but in the office, I do nothing at all except treat patients and do documentation. When those things are done, then I go back and answer emails or do those things. If there are reports to be written, cards to be done, anything patient-oriented gets done during those times. I do not waste any time from 9 to 1 and 3 to 6. It is high-octane time. So I think a lot of you, especially if, I'll be honest with you, I think it's easier to do this if you're busier because you're more focused and there's less downtime. But if you've got 2 or 3 minutes in between patients, that is when I am getting a lot of my notes done. So you're getting it done in between patients. And even if I get a third of the note done, then 2 or 3 more patients comes in, I go back and finish another third of the note. Sometimes I'll start on my new patient note while the patient is in the exam room changing, so I can start putting in the things I already know because I've done my consultation with them. So that's the way. You've just got to be very, very, very disciplined. So for many of us, we're going back to check our email, or we're taking a lot of personal calls, or you're selling real estate and all that stuff. That kind of convolutes the process. So I'd encourage you to kind of keep that discipline because it makes it a lot easier. So those are my thoughts on that. Any other thoughts? Good. Great. All right, let's move on. All right, so summary. The healthcare record will include, but not limited to, the patient history, as well as family and social history, chief complaint or complaints, the results of the exam, diagnostic studies performed, the results of those studies, diagnoses, clinical assessments, OAs, treatment plans, and objective, measurable, and reasonable treatment goals, evidence of informed consent, treatment rendered, including adjustments, modalities, instructions, advice, and recommended follow-up, patient's response to treatment, and objective evidence of patient's progress towards treatment goals, and lastly, when the patient has reached MMI. Whoops, not lastly. And then also evidence of when you discharge the patient. That's something that is often missed in your notes. All of a sudden you just stop and you explain what's going on with the patient, whether you send them to supportive care, whether you're releasing them, PRN, whether you're sending them to another physician. And again, it's not an exhaustive amount. You just need a few sentences to explain what's going on with that.